try one more, try PCI and see if body's working for many years. So at the time, so I considered the BRS because considering his young age, especially for ISL. So there is an angio-guided approach versus IVUS or OCT-guided approach. I like to compare it. So at the time, next slide. I just treat the RC proximal lesion with the BRS BVS 3.5 by 23 millimeter and postal adjunctive balloon 4.0 without IVUS, without OCT. So what I believed at the time was the expansion, full expansion is the most important, even in angiographic evaluation. So I left for you the LED lesion as. Give me the today's angiography. So this is a lesion today. Okay, angiographically okay. So I like to see if it's well done without the angiography. So what do you think? Is it okay with we checked IVUS and OCT, and we got the answer now. And what do you think?
And Dr. Gwon, would you please show us angiogram 9 years ago?
9 years ago.
네.
Slide. 9 years ago.
Yeah.
Oh yeah, I'm sorry, we didn't prepare it. The angiogram, the diffuse lesion from the RCA to actually this RCA was totally occluded, and left main LAD ostium to a medial LAD lesion. So.
You may have strut fractures, which is not visible on angio because you use a half-size balloon bigger for post-dilatation. Normally in our practice, we use just a quarter-size bigger balloon, but we apply high pressure inflations more than 16 up to 20, for example. With high pressure, you won't induce a fracture.
Yeah.
But
fracture over BRS,
with half-size bigger, it is quite often that on angio you see perfect result. But if you use OCT, for example, you will see fractures or struts hanging into the lumen.
Yeah, is that a problem? The kind of fracture is a problem in the long-term outcome? Usually, fracture in BRS is quite stable, and I'm not sure stable fracture is the cause of.
Dr. Gwon, we can't hear you.
Dr. Gwon,
We can't hear from you.
something wrong from the Samsung, the audio system.
And Dr. Philip Urban, do you have any experience?
3 years later.
Yeah, of course.
Okay, let me show you OCT image today.
On the right, the first one.
OCT, please.
What was the final balloon size for BBS?
The
4.0.
4.0. Okay. Yeah. Start. This is distal. The stand. Stay there. Stay there.
You can stop
Back.
here. Yeah, just back.
Okay. This is metallic stand. Okay. Upward. Approximately. Okay. There is some bellow position here distally, because I didn't post dilate to 4.0 at this point. Actually, I dilated only the lesion in the center of the BRS. Okay, going up approximately. So distal. No, too fast. Distally, the position is okay. The bellow position segment is less than 2 millimeter, I think, but the embedment at this moment is not so great. I'm not sure.
Do you think embedment is possible within the stent already? So I'm not sure that you can do better than that.
I don't know. I don't know.
Because we see the layer there of neointimal hyperplasia is not very thick, so embedment maybe not possible.
Yeah, it's impossible to. And approximately, you can see some thrombus of a remnant plaque. Proximal, this proximal edge.
This is proximal. Proximal is well deployed and well opposed.
So, how do you think?
You want to do an IVUS or not? For me, I'm happy with OCT, but I know that Hyeon-Cheol is.
Do I need to treat this malposition?
Which one?
Yeah,
Well,
this
distal
one.
malposition, yeah, distal malposition, which is okay, a ring, one ring probably, no more.
Well, I think currently we don't have international consensus on how to treat malposition after BVS implantations. But normally, if the distance between the struts and the vessel wall is more than 250, then normally we try to fix it.
Okay,
But there is
this
no
is the less
international
than.
consensus.
Yeah, this
And
is
the-
about 100
The
micrometers.
problem is there that we are at the very last ring, and the problem is to create with a 4.0 to create a dissection distally. So
Yeah.
I'm a bit, I'm not in favor of doing anything on this very limited malposition.
Yes, it looks like the
Okay.
overall imaging is okay for BBS. Good job. So you're gonna do the LAD today?
Yeah, so,
Yeah.
but I can show you the IVUS to
Okay.
compare it, and we have a chance to find that the IVUS can find the malposition distally. IVUS, please. Today's case is simple, but so I like to show you a lot of images.
Rich hospital.
No, just for live demonstration. Okay, you can see IVUS distally. So yeah, this is maybe the distal edge of the BRS, right? Okay, can you see the malposition?
Personally, I don't see
Yeah,
anything.
distal부터
No, I
play.
don't.
Play. Okay. Here is the distal edge.
I
Okay,
think
so-
we're seeing better with OCT, in my opinion.
Yeah.
But,
But I like to mention that the vessel size is very clearly seen in the IVUS, not in
Yeah,
OCT. So in this IVUS view, I am sure that the BRS is really well expanded inside the stent, and also compared to vessel size.
yeah, also it's a 555 BRS, and you took a 4.0 balloon, that this is the limit of expansion. So after that, the risk of fracture of the BRS is high. So I think this is for me, a
Yeah.
very good result with only one ring with partial malposition.
So what do you prefer, the OCT or IVUS for BRS?
For
or
BRS,
yeah.
I prefer OCT. I'm not
OCT?
a specialist of imaging because the number of imaging we are doing in France, as they are not reimbursed, is very limited. And for me, it's, I read more easily an OCT than an IVUS. So for me, OCT is the one we use for BRS
Actually,
implantation.
for me, it's IVUS, actually. The vessel size, stent size is most important factor. So expansion is most important. So for that, I think the vessel size evaluation is the most important. So that's why I use IVUS rather than OCT. Okay, let's go to the LAD. Angiography. Okay, this is today's angiography. So the lesion was just distal to overlap. You can see there is a dense two struts, and there's an overlapped segment. And
three rings that overlap here, we see. And after the three ring overlap,
Yeah,
we
yeah.
see this. So we are discussing about stent fracture there. Because at the end of the stenosis, at the top, we see something which is maybe a calcification or maybe a strut protruding outward.
down.
So we did this stent boost, not a stent boost,
Not the
really,
stem boost.
but just to see if there are some reason to think that there is a fracture. Personally, I don't see any mobility in this part, and I don't think there is a fracture. What we see is a difference in diameter between the proximal stent and the distal stent. And this is comforted by the data we have. This is a 3.5 proximally and 3.0 distally. So maybe was a factor, I mean the flow factor for occurrence of of restenosis there. I don't know.
So anybody in the panels think there is a stent fracture?
No,
Yeah, I
there's a-
agree that this is a strut fracture, at least angiographically or on fluoroscopy. And I think the best thing to diagnose is, the best modality to diagnose this is with OCT. You can very
Yeah.
clearly see that in that area you don't
Okay.
see struts.
Yeah.
Dr. Gwon, this is Dr. Ross from Korea University.
Yep, yep.
One of the simple measures to just insert the balloon and do the stent booster image. Can you do the stent booster to see
You don't have
the?
stent boost, and I have never.
You
used
don't
it.
have really.
Sorry.
Oh, very strange. The stent
Okay.
booster easily identified all the
Yeah,
stress.
I know that.
Yeah.
But
Uh,
in the clinical practice, I have no. I have not. I am comfortable with that, even without the stent boost.
Hope you
Okay,
install.
so. Okay. Yeah. Okay, so but I can see in this view is that the distal stent is not well expanded.
Yeah.
Again and again, stent expansion is the most important factor to treat. This is
Yeah.
related to the clinical outcome. IVUS data, angio data, every data show that the underexpansion is the cause of the event, not the malposition. So we did the OCT, right? OCT, please. Actually, we pre-dilated with the 2.0 balloon to facilitate the clear, to make a clear image from the OCT. This is the distal. Maybe underexpanded, then
Yeah.
I'm not sure. This is a lesion.
I've seen the septal also. This is proximal.
This is proximal. So go back to around the lesion and see if I couldn't tell, but see if there is some stent fracture or not. Distal to proximal 천천히. Okay.
You see
Slow.
absence of the
Struts.
absence
Yeah,
of
shadow.
struts, yes.
Slowly. You
Well,
can see struts.
Right there, see?
Here.
Yeah, yeah. correct.
Okay, here. Yeah, very short segment
There must
of
be some strut
fracture.
fractures, yes.
Okay.
You don't see the
Okay,
sundry
maybe you're
appearance.
Yeah. Yeah, very nice, very nice. I agree with you. Okay.
So this is
That is a very short stent fracture. Very sensitive. Yeah, I learned that. Okay, Ibis, please. Ibis, okay.
Just a question. A small stent fracture, it's interesting to see, but does it influence your treatment? Will it make a difference in what you want to do?
Please ask Dr. Santoso about that.
Personally, I will be a bit resistant to put a BVS in a stent fracture, but
In
if you
situation
put a
like
new DES, we'll have 3 layers of stent. So this is a balance between a 3rd layer of stent and the BVS, which will remain to only a small overlapping. So this is, no, I don't think we have data to answer
Yeah.
this question.
The treatment option is the BRS, considering his young age, to avoid the 3 layers and the overlapped segment, or just the DB.
Yeah,
Yes, we have the small fracture. If without a fracture, the DB is working well
Well,
in
yeah.
this very short segment. And there is a fracture, maybe we need the metallics, the DES. Actually, as of early September, BRS is not available, stopped the delivery, actually available so far. So I'm a big fan of BRS, actually, especially
Yeah, we are
for the young
too in
patients.
France, and we are very, very disappointed by the decision of removal. And even more in Europe now, we have, this is not EU marked as it was. So in fact, it means that it's forbidden to use it, except it for a research purpose. So we cannot use in France today a BVS.
in my
So
practice.
the question, in my opinion, we have data showing that in big vessel 3.5 like this one, DES is doing better than balloon delivery drugs. And another reason why not to use the regulating balloon is that if there is a stent fracture, it won't solve the problem. So in my opinion, we have to choose between new DES and BVS. So that's the question. In France, we'll put a DES because this BVS is no more allowed.
In my practice, if I have restenosis associated with strut fracture, if the vessel is big like this, of course, one option is to use DEB, but with DEB, you will still have the strut fractures, and over time, the patient, the lesion may develop restenosis again. The other option is to use DES, but we have to choose a thin DES, otherwise, because we will have 2 layers of metal. But the other problem is that we can have secondary fracture after implantation of another DES long term. So the third option is, of course, to use BVS, and BVS can be used if the vessel diameter is big. So we won't have, theoretically, we won't have a double layer of metal, and over time, theoretically, after the area is already fully endothelialized, and BVS is already fully absorbed, we will have that area fully covered with endothelium, even though there is still fractures. But I have to admit here, one of my patients developed aneurysm formation in that area, and patient died suddenly. So I think there is still no perfect treatment for this kind of situation.
Yeah, actually, about 10 years ago, in Korea, we have a registry of a stent fracture by Dr. Jung, actually, at the time. So most of a stent fracture is quite stable, not related to an event, if it is very short and not displaced. So I'm not sure this kind of small stent fracture should be treated and considered as a factor for treatment. So I'm not sure.
What we have seen was the absence of a strut on OCT, and when we look at we have seen on the short CNA that there is no abnormal movement in at the place of the supposed fracture. So in my opinion, I think we can choose both of options, or having a third layer of DS or using the BVS. I think if you have it, probably the best is to put a BVS.
Actually, there are a lot of stent fractures if you use CT angiography. So you even don't know that.
Yeah.
So still another issue here is that do we need to protect the septal branch? Actually, ISL is that a lot of plaque burden is a high risk of stylomas occlusion, and the first septal is important and large. So usually I don't protect the septal branch, but the ISL I protect it.
The reason against this will be maybe you have not seen that if the left was collateralizing the right was also collateralizing the left through the septal. So this septal probably will work in the other coming from the right. So, but I think okay, we are saying in bifurcation clubs that each time you can protect a big vessel, it's important.
You think a septal branch is already protected from the RCA? Okay, that relieves my concern. Okay, so.
So do we plan to dilate the septal now?
I think I thought if it is very difficult to wire the septal branch, I don't like to protect it. But it's anyway a successful wiring after the pre-dilation 2.0 small balloon in LAD. So why not? We pre-dilate 2.0.
It will be easier now than after putting the BVS. Maybe difficult to enter such a branch.
So have you decided?
Even if it's not closed.
Have you decided what strategy we'd use, DEB, DS?
Personally, I will use the BVS because we still have it here. I said already that I will use the DS in France, but we are not in France. So I dilate the septal branch. Meanwhile, I ask panelists, and what is the best option? DS, BRS, DEB? Please advise me.
Okay, how many panel wanna put the DES? Raise your hand. The question one is DES, and question number two is the BRS. Number one.
Dr. Gwon? Dr.
Yeah.
Gwon?
Yeah,
If you
I'm
have
busy.
any DS or BRS or DB, if you fail this case, what can you do? Is it at the time you have surgery?
Failed? Fail means the restenosis?
Yeah.
I haven't no thought about the failure of a procedure.
So
The failure means what is the expected failure in this case?
I now see prosthesis is okay, but in the long
1.5.
follow.
The restenosis, you
yeah,
mean?
restenosis
Restenosis.
again. Yeah. What can you do?
Those are restenosis, yeah, but okay.
Depend on the type of restenosis, actually. The short lesion, we can try again. The diffuse restenosis, maybe
Yeah,
I
yeah.
send patient to surgery, but if there is a lesion in the LAD, I put the Lima to LAD, but later he got the lesion in the RCA.
Yeah,
And
yeah.
there is plenty of time in front
He's young,
of
I think. To
Yeah.
have a monovessel surgery, I think he's too young. So for me, seriously, it's not an option.
Doesn't matter with the LV
Rationale
function.
was the ISL is there is plenty of a plaque, and COPIS 2 registry showed that a lot of plaque is the most important risk factor for side branch occlusion. But as Dr. Luvat says, it's protected already from the RCA, so I'm not so enthusiastic.
The symptoms are not related to the septal branch, but sometimes when you close the septal branch, you have symptoms. So and it gives some CK the next day. And if you are taking care of a database, this is theoretically a failure if you have 3 times the CK elevation. So, okay, this is minor. This is a minor vessel, I agree. And in my opinion, is also protected by the right because we saw a collateral filling from right to left. But okay, it's not difficult to do. We don't plan to put a stent in the septal, just to keep it open.
So angiographically, actually, most side branch except the circumflex are not important for long-term outcome. Still, we are concerned with the side branches. So for this
for
septal
long-term
branch,
outcome, but you know, at acute outcome. I mean, the CK you have the next day. Some people say that it's not, also not important, but if you years after years, if you occluded one time a septal, a second time a diagonal, a third time a marginal, then at the end it will be important for the patient.
So what's the result of aborting? Stop.
Okay.
Deflation.
Dr. Gwon,
Yeah.
can you hear me?
Yeah, I can hear you.
Yeah, we have to visit to Seoul National University
But
Hospital live.
I like to know the result of aborting, Dr. Jang. So we already finished the procedure, and I can still patient is here. And if you like, we can do it again. So this is where you left, and we pre-dilated with the 3.5 NC balloon, but it won't expand. That's the problem. So we tried up to a 24 atmosphere with a 3.5 NC balloon, but it won't give. So that is a strong contraindication for BRS, actually.
Yeah, we tried even more. We tried 28.
Yeah, 28, right.
At the 28 was a bit better.
Yeah. And but tip was the prolonged inflation, you mean?
Yeah. What I'm using when I go to 28, I try to do a long inflation. I ask my partner, as soon as the pressure is decreasing, to push it again 28. We call it the balloon is working, and if it's working, you have to put it back to 28.
Yeah.
And after 1 minute, it was a bit more expanded.
Yeah, prolonged inflation. So this is about 10 seconds after the inflation. 10 seconds and 30 seconds, 1 minute. Yeah. You think you can see some expansion in the MLD area?
Still imperfect.
Yeah. Still underexpanded.
Yeah.
So we try to dilate distally too. So and you put the DS. DS.
No, this is again predilatation. I know this was a DS.
DES. So the
3.5,
3.5, 12. We tried to put the shorter balloon. We avoid a dog bone effect with high pressure implantation. Still, there is still residual stenosis, and we use we apply the NC balloon again up to 28 atmosphere for 1 minute, prolonged inflation. Okay, this is angiography, residual stenosis. You can see more residual stenosis here, but we have a very interesting the OCT findings. So please show us the OCT.
In case of resistant in-stent restenosis, another option would be to use rotablations. So since this is a 7 French guider, we can use up to 2.0 millimeter per.
Right. But 7 French actually is very difficult to use 7 French 2.0. But the stent is we should dilate more than 2.5, 3.0. So it's very difficult to ablate the stent, even ablate the stent, the calcification in this large vessel. But rotablation is another option, I think. So this is from distal. Can you see the OCT? Okay. It's round. Here. Stop. So this is very eccentric, right? There must be, in 9 o'clock, there must be the calcification. I can see it clearly.
Yeah, we see it.
Yeah. So but area of in this at this moment is large MLA. Where is it?
6.6.
6.7
square millimeters. Yeah.
6.7 square millimeters, a large lumen, but eccentric. So this was the best we can do, actually.
How was the overlap side? There's a 3-layer overlap stent, 2 cipher and
where
1
is the
cipher.
3-layer site?
Yeah.
This is the two, approximately. No, it's the. It's
Yeah,
very
the 3.
Yeah.
That's 3. No, not 3.
No.
There.
Okay.
It's difficult
So-
to find.
It's difficult to see.
Yeah.
So your patient is very high risk for stent thrombosis. So do you recommend new anti-platelet agents?
Yeah, just
Yeah,
I
we have 3
continue.
layers. Here we have 3 layers.
Yeah.
1 to 3.
Yeah, in the 12 o'clock, we have 3 layers.
Okay.
But I'm not sure that MSA stent area or just one diameter, which is more important for stent thrombosis.
The
Traditionally,
diameter is
IVUS study showed that the MLA was a strong predictor of stent thrombosis, and not the diameter. So I think I am comfortable with this large enlargement. So 6.7 at the MSA.
Yeah. And the previous stent was implanted 9 years ago. So I don't think the risk of stent thrombosis is high now.
But polymer still remain the LAD, and usually cipher stent associates severe inflammation due to polymer reaction. And target region is still underexpanded.
But for 9 years, the cypress tend to make other problem in the very long stent, but two focal lesion.
2 focal lesion,
Yeah, so I'm not sure. Another issue is that there is have you noticed that there is a myocardial bridge distal the stent?
Yeah.
They might affect the stent fracture in the LAD.
Not sure. I think the stent fracture was a result of was immediately after the overlap, and was the result of both of a difference in diameters, moving from 3.5 to 3.0 without bifurcation, so without reason to tapered. And maybe this was the factor in this fragile point for the stent fracture.
Anyway, we didn't lose the septal branch.
No, septal branch.
He's lucky.
Dr. Pond's study showed that the
No, it's not
predilation.
lucky. This is balloon. Another option we have in our cath lab is not working on the strut, but working on the tissue behind the strut with a laser. And after you cross with the laser, and after that you use a high pressure balloon, and you can get adequate diameters.
Actually, we have talked about cutting balloon and scoring balloon. If tissue is very hard inside the stent, it will work. But as you can see here, the OCT and the angiography, mostly stent is not well expanded, eccentrically expanded. So scoring balloon and cutting balloon doesn't work in that situation. So we prefer a high pressure balloon.
Still,
Okay.
So, thank you.
still it will work with the high pressure
Yeah,
focal
Still.
balloon. Yeah.
Why?
We'll know the truth in 6
you-
months or 1 year.
Scoring balloon can remove
Yeah,
the flag
scoring,
outside of a stent?
Yeah, plug modification is limited. However, the shorter NC balloon with the maximum pressure
Yeah.
will work out.
Yeah, we applied to 28 atmosphere.
What is the length of the NC?
Yeah.
12?
So there is some debate about the shorter balloon is stronger than long balloon.
I
In
don't think
case
so.
of NC balloon.
Yeah,
It's
definitely
Laplace
shorter
law.
balloon.
The answer
Yeah.
was no.
Shorter balloon is more effective. We can feel it in clinical
Yeah,
practice.
there is debate, but in Laplace law, this is mathematics and the physics.
Yeah, I remember
There is
that.
no difference in short balloon
long time
and the
ago,
long
yeah.
balloon. Yeah.
I
Okay,
remember
there will be a
Laplace.
debate.
Laplace was a French mathematician.
Okay.
Dr. Gwon,
Okay,
So
you
thank you.
finish?
Dr.
Thank
Gwon,
you.
Yeah,
I'm
I like
Thank you very
from
much.
Hyeon-Cheol University. So